Okay, so tonicity and fluid shift. This is why I covered that tonicity. I really want to make sure you're looking from the outside in. You can easily put in an IV. You can't inject, or it would be unreasonable in terms of therapy to inject every single cell with a different small, tiny microscopic IV solutions and change intracellular fluid directly. So you're probably going to use an IV, or the nurse is going to use an IV. So intravenous fluids, these can be used to balance the osmolarity of the intracellular and extracellular fluids. So the thing is that move IV tonicity by using osmosis, by using a more dilute or isotonic solution or a more concentrated solution, you can either allow water to diffuse via, or actually allow water to move into cells via osmosis, or draw water out of cells via osmosis. So here we have cerebral edema. So over here in white, we actually have a tumor. So this tumor is causing cerebral edema. Edema is seen by this darker region right here. So this is fluid as accumulating in this area. So what do we have here is that, and this is a really severe example of cerebral edema. So notice that you can still see some of the folds, the sulcuses and gyri inside of the brain. You can see some of the ridges. But this brain is so swollen and with interstitial fluid that you can barely see the folds. You can barely see the sulci in the brain, cerebral cortex of the brain. So this brain is being pushed against that skull, and it's being pushed with a lot of pressure. Not only is that harmful to the cells, you also have a lot of vasculature. You have a lot of arteries and veins in your brain. So if these arteries and veins are being pushed via a very turgid brain across on this very hard bone, that's going to choke off those vessels. So this is a very critical situation. So you have too much fluid in the brain. Do you want to remove fluid from the brain, or do you want to add fluid to the brain? Well, again, you have too much fluid, so you want to withdraw fluid and draw it out of the brain. So again, look at this other example of edema. Look that all these folds are pretty defined. But in this brain with edema, notice that this brain is very waterlogged. All these gyri, these folds are very plump. And you notice that the folds are not as well defined and they're more squished together and shallower. So how do you treat cerebral edema? Well, you can use osmotherapy. You can use IVs to rescue someone from cerebral edema. So how do you reduce the swelling? You want to draw out water. So are you going to draw out water with a hypertonic or a hypotonic solution? So again, we're talking about the IV solution relative to the inside of that tissues and cells. So remember, we want something that draws water from the cells into that extracellular fluid. So how do we reduce the swelling? Use osmosis to draw out fluid. So you're going to use a hypertonic solution. So your hypertonic solution, this is going to draw the water from the tissues and cells into the extracellular fluid, the blood plasma as well. So you want to move that water into your vasculatures and your vessels versus waterlogging the tissues and cells in the brain. So mannitol, oral glycerol, this can be used to increase the osmolarity of your blood in your patient. So this can draw out water from the tissues and cells in the brain. So they used to use our urea, but I think that's obsolete now. So this is where you'll have that 20% mannitol. But the thing about this, remember that this is going to draw water out of cells. And now the thing about this, it's not, even though you're trying to draw water out of the brain, can you just do a simple IV line in the arm? Thing is that you have all the blood vessels of your body are also lined with cells. So if you just like do a simple IV with a hypertonic solution into the arm, that's going to draw water from all those endothelial cells, and that's going to be very bad for the blood vessels in there. So you don't want to cause damage to the vessels. So when you have a hypertonic solution, it's typically given via central line versus in a peripheral blood vessel, because again, this is going to draw out water via osmosis from any cell encounter. So this is why central lines are typically used with hypertonic solutions and given via for osmotherapy. Now, Now let's talk about diabetes insipidus. You might be familiar, so you hear diabetes, and when people think about diabetes, you typically think about diabetes mellitus, but they're not the same. Diabetes mellitus, when you think about things like insulin and blood glucose, you're typically thinking about diabetes mellitus, but diabetes insipidus is a different thing. What they're both called this diabetes, and what they have in common are polydipsia, which is increased thirst, and polyuria, so the increased production of urine. So these are common things you see in both diabetes mellitus and diabetes insipidus. But the difference is that diabetes insipidus, you have dilute urine, so you have that polyuria. But the solutes, so things like the sugars, the salts, are retained. So you have the kidneys and producing a huge volume of watery urine. But now the salts and the sugars are being kept inside of the blood plasma of your patient. So what does that mean in terms of plasma osmolarity? Well, if you're starting to remove water from a solution, but you're still keeping the solutes in there, such as the sugars, the proteins, and also the salts as well. Well, think about it. What if you leave a pot boiling on the stove? So, say you have a soup, and you leave it boiling, and you just let it boil over time. So all the water starts to evaporate and remove from that solution, that soup solution. But things like everything that's dissolved in it, all the salts, all the sugars, that's going to start getting more and more concentrated. So in diabetes insipidus, what happens to the osmolarity of the patient's blood plasma? It starts to get more and more concentrated. So what happens to the cells? Well, if their plasma, their blood is starting to get more and more concentrated, what is that going to do to their cells? So again, we're talking about which way are you looking at? Are you looking from the outside in or inside out in terms? So we're looking at the blood, the extracellular fluid compared to the cells. So if the blood is getting more and more concentrated, it's going to draw water out of the cells. So the cells are going to be dehydrated because why? Again, it's trying to balance out the concentration between the blood plasma and the cells. So the cells are going to get the water sucked out of them. So in diabetes insipidus, what type of IV should you use? Should you use a hypertonic or hypotonic? Well, what's happening here? Your plasma is getting more concentrated with solutes. It's losing water, and this is causing your cells to lose water because the increased osmolarity of the plasma is drawing water out of the cells. And that plasma is going to lose water due to the dilute urine being excreted. So you want to reintroduce water, but here's the catch. Do you want to use an isotonic versus hypotonic solution? So there's evidence for using both, but if you're, say their sodium, with their sodium or the solutes being retained, say they have hypernatremia or hyperkalemia, where they have too much sodium or potassium respectively. So you don't want to, you want to limit the amount of additional solutes you add. So say if their electrolyte balances are way above normal levels, you might want to give a hypotonic solution, so you're giving the water back into their extracellular fluid and eventually back into their cells without adding too many additional solutes that pushes their electrolyte levels further above the normal range. Now, endocytosis